The topic which we are going to discuss today is laparoscopy the gold standard procedure for inguinal hernia repair? Now, we all understand that laparoscopy has come a big way in cholecystectomy, in appendicectomy, in diagnostic laparoscopy. But what is the role of laparoscopy in inguinal hernia repair? Where are we? If you read the newspapers, if you read the journals, if you read the conferences, the picture is something different. But when we go inside, we find there's an entirely different picture. So today I will be discussing a bit controversial topic, and as I go around my talk, you will understand what I'm going to say. Is laparoscopy the gold standard procedure for inguinal hernia repair? Now, this laparoscopic hernia, when it came, we have to first understand, is it evidence-based or it is eminence-based? You should understand that laparoscopic inguinal hernia, when was brought in 2018, the hernia journal brought international guidelines for groin hernia management. So when a hernia surge group came and they brought guidelines. Then in such and such condition, we must do laparoscopy. In such conditions, we should not do laparoscopy. So a set guidelines was set in 2018 and was published in the journal Hernia. Ladies and gentlemen, please remember this slide. I'll come to it at the end of my talk. This was a journal which was Hernia published international guidelines, and I'll tell you what has happened, how this guidelines was published and how the thing was. When the guidelines came, everybody started following that. We didn't understand how those guidelines was made, but we started following. Now, laparoscopic surgery for inguinal hernia, the current status and controversies. We started discussing, let us go in hernia repair with laparoscopy. Let us see how that works. And inguinal hernia repair, what to do with the evidence? There was a lot of evidence saying that open hernia is good enough. But then we wanted to do laparoscopy. There is a very famous quote by Sir John Bruce who said, the final word of hernia will probably never be written. In collecting, assimilating, and distilling the wisdom of today, we must provide a base from which further advances may be made. So here we start we were doing very comfortably open surgeries. We were now going for laparoscopy. Now this is an Indian movie. I do not know how popular is Indian movies in Sudan, but this is an Indian movie where, you know, the surgeon is, this is surgeon. Surgeon is very fond of doing open surgeries, but he wants to embrace even laparoscopic method. So that is a problem of surgeon's dilemma. Though they were very comfortable with the open method, but then laparoscopy came. It is a minimally invasive surgery. There was a lot of discussions, and we thought maybe it is as good as laparoscopic cholecystectomy or laparoscopic appendicectomy. So we wanted to adopt that laparoscopic inguinal hernia. So that was a condition. There were surgeons who were not knowing whether to do open or whether to do laparoscopic hernia. Now let us see the breakdown of a hernia, laparoscopic hernia done in the world. You know, if you see that this chart, open surgery takes almost 85–90% of cases are done by open. Still, it's only about 10% which is done inguinal hernia done by laparoscopic inguinal hernia. So now that's the reason. Why is that reason? That unlike in cholecystectomy, where laparoscopy is a gold standard procedure, why is it not getting accepted in an inguinal hernia repair? So there was a lot of points where there was a disagree, agree, undecided. You were not very sure what was the thing. And as my talk goes, you will understand. I'll make you exactly the point. What is the problem with laparoscopy? Now, what is the popular opinion? A survey was done in surgeons regarding laparoscopic inguinal hernia, their practice, the patterns, the barriers, the education needs, everything was there. And then the conclusion was, many surgeons who do not have the volume to overcome the learning curve may not be wanting to start laparoscopic inguinal hernia repair for challenging cases. See, that's the important thing. For doing a laparoscopic surgery, inguinal hernia, we require quite a number of learning curve was there, and we require a volume. If you keep on doing, only then we can get trained in laparoscopy. Otherwise, it was very difficult. Now, before that, we must say how common is inguinal hernias. See, 2 out of 100 women will get an inguinal hernia, whereas 25 out of 100 men will get sometime in their lifetime an inguinal hernia. So that's very common. So that is the reason this topic is very important. that we must know, because it's so it is so common. The hernia problem is so common that we must understand which method to adopt and which method to do in a proper way. Now let us see the history of evolution of hernia repair, inguinal hernia repair. If you see, the first hernia repair came in CAPFs Tomer. It was something around 1680. When they used to almost, cauterize the entire scrotum. It was a very crude method. They used to cut the scrotum, they used to ligate the scrotum, they used to sometimes amputate the scrotum. So that's how they wanted to do they started. This is a picture from Egypt. They also started reducing it by forcibly. This is an Egyptian picture. Then there was a lot of Lord Schulde's repair and Bassini's repair and all those things. But the first really established hernia repair came from Lichtenstein. Irving Lichtenstein. He published his data in 1970. If you see this. Now, Lichtenstein was the first person who gave the concept of doing a tension-free hernia repair by using a mesh. So this method was well established and well accepted all over the world. So Lichtenstein was the first person who in 1970 or 1964, he gave the method of Lichtenstein's inguinal hernia repair, which is still the gold standard and which is still fighting with laparoscopic inguinal hernia. And this is the reason, this Lichtenstein's repair was the reason why laparoscopy is still not getting established. Anyway, we were talking about the history. Nyhus has famously said the history of hernia repair is a history of surgery. So you can understand, if the entire history of surgery is on this history of hernia repair. Now, in summer of 1990, this was the first person, Ralph Ger. He brought the laparoscopic repair technique, which is a TEP, and the TAP, and then TEP was, that is total extraperitoneal repair, was brought by Liam and Van der Graaf. This was the paper published in 1997 in New England Journal of Medicine. So this was the American Journal of Surgery. The first gave the concept of TAP. The New England Journal of Surgery Medicine published the first case of TEP, that is total extraperitoneal repair. So these were the two laparoscopic method published in around 1990 and 1997, and then the fight started, whether to do Lichtenstein repair or whether to go for laparoscopic inguinal hernia repair. Now in India, we have so many discussions, we have so many YouTube videos on laparoscopic hernia, we have so many workshops, we have camps, we have journals. We have conferences only for hernia conferences. So blah, blah. But then at the end of the day, the debate still continues whether we should go for open tension-free mesh repair or we should go for laparoscopic inguinal hernia repair in inguinal hernia surgery. And what are the pros and cons? Now the thing is, what is the logic for laparoscopy? Now I had I wrote to Robert Fitzgobbins about this, and he gave me a reply. He said, if you are repairing a tear, do you want to place a patch on the inside of the tear or outside? In the laparoscopy repair, we are placing a patch on the inside of the abdominal wall rather than the outside, as you do in the open procedure. So that's you can understand what he's telling. Robert Fitzgobbins was the editor-in-chief of the journal Hernia once. Now, in India, what is the rationale for doing a laparoscopic hernia repair? One of our first person who did laparoscopic cholecystectomy in India was Dr. Tempton Udwadia, and he said very clearly that a procedure which can be done by laparoscopy is not adequate indication to do so. So we may be in a position to do a laparoscopic inguinal hernia, but is it the reason we should do it? We should see the pros and cons. So is laparoscopic inguinal hernia repair more effective than open hernia repair? And that's the reason. If you see the conclusion, this was a paper which says both total extraperitoneal repair and Lichtenstein repair are clinically effective procedures. So there is balance. We are not able to say laparoscopy is the best. So what should be done? The choice between them should be made in case-to-case basis, which depends on the patient's preference and characteristics such as age, work, and health status. So if we say laparoscopic cholecystectomy is effective than open cholecystectomy, we say yes. But in a hernia, we are not able to say that. And why should we not do open repair? What are the pros and cons? What are the difficulties? What is the reason why we should avoid doing open and go for lap? Again, there was not much of answers. Now, the first most difficult thing in the laparoscopic inguinal hernia was there was a fearful laparoscopic anatomy of the pelvis, which was not very clear to the surgeons. In the open hernia, you can see everything is very clear. You have a inguinal ring, you have a superficial ring, there's a deep inguinal ring, the contents are coming like that. You can open and you can put a mesh. So anatomy is very clear. Whereas in a case of laparoscopic inguinal hernia, there was a very difficult hernia anatomy, and it was also a dangerous anatomy. If you look at from inside out, there was something called a triangle of doom, which there is a lot of vessels, external iliac vessels. I know all these vessels are there. If by chance you make a nick here, there's a problem. So that's known as triangle of doom. Then there is a lot of nerves there. There's a nerves there. So that's known as triangle of pain. And then, there's a corona mortis, that's known as circle of death. So all these names itself is so much of worrisome for the surgeons, surgical. Imagine doing a new surgeon whom you say there's a doom, there's a pain, there's a death. He will run away. He will simply say, I'll go for open hernia surgery. Because these are the problems. The anatomy was very difficult in a case of a laparoscopic inguinal hernia. And that's the reason why people were not very interested in this surgery. Now, what are the positives? What are the advantages of open hernia repair? See, though we say laparoscopy has less pain, it has a faster recovery, the advantage was only in bilateral cases and in recurrent cases. So in a case of bilateral inguinal hernia repair, or when there's a recurrence of inguinal hernia, then only of course laparoscopy is okay. But it has got a more operator dependent. Whereas open is easy to learn, as I told you, it is reproducible and having a fairly good results. So open is good enough surgery for us. Now the most important thing is, you can see that Lichtenstein himself has said that we can do open inguinal hernia under local anesthesia, which is not possible in a case of laparoscopic inguinal hernia. Laparoscopy will always require general anesthesia. And another problem was post-op mesh infection, which is a concern in laparoscopic hernia. You see, I'm quoting all the journals. I'm not saying my own data. This is another problem, which the reason why laparoscopy was not very popular, because of this mesh infection. And what are the complications of laparoscopic inguinal hernia? If you read all the complications, I think all of us will really run away from this surgery. This has got something called a maximally invasive complications after laparoscopic inguinal hernia. And mind it, again, I'm saying these complications are all documented or all published data. I am not quoting from my own resources. They're all published. You can see in the journal, everything is in black and white. There has been an accidental inferior epigastric artery injury. There has been orchidectomy as a result of ischemic orchitis. There has been a uremia after laparoscopic hernia. There has been a occult trocar injury to the inguinal nerve, and then there's a fistula in the sigmoid fistula. There's no obstruction, intestinal obstruction. All those are the complications of laparoscopic inguinal hernia, which we hardly see in open surgeries. Then there was again, you see, what are the complications of laparoscopic hernia? There was a pseudoaneurysm. There was again a delayed mesh infections. There was a obturator nerve injury. There was a mesh erosions in the urinary bladder. Then there's a mesh migration in the sigmoid colon. Then the port site tuberculosis. All those things are there in the literatures, and many. I can go on enumerating the complications, and it's very, very dreadful. And the last but not the least is this. There has been a mortality, a death after a laparoscopic inguinal hernia. Have you ever heard of death after open hernia? We never hear death. But laparoscopy, there's journals which shows sudden death, then unexpected fatal outcome. And if this occurs in my town, there'll be a lot of problem in the hospital. So, these are the very, very problematic things which does not make, there's a reason why laparoscopy is not coming into a method of choice, or a surgical method of choice for hernia repair. And then next thing is, because there are so many complications, the problem is the medical legal, I do not know how is it in Sudan, but in India, there is a lot of medical legal issues. If the patient finds any problems like that, they'll go and sue the surgeon. So In a case of laparoscopy, the surgeon gets suing is the surgeon being dragged to the court is very high. And the litigation is also very high. Even in UK, you can see litigation after groin hernia. So all these things, because the complication was very high in a laparoscopic hernia, the patient also started getting litigation also. So all these things were the problem of a laparoscopic inguinal hernia repair. And there were lawyers who were moving like a card like this. They knew that there would be a problem, so they were having a visiting card like that. Hernia mesh injury claims. The lawyers are moving, and you see what they are writing. They knew fairly well what is the problem. The problem is going to be there, and they write the last line: no fees or expenses unless and until recovery is obtained. So they were not even willing to take the fees because they knew that the patient is going to get a lot. The surgeon is going to pay a huge amount of money as a compensation, and then the lawyer is going to be compensated from that. So that's the way, that's the confidence the lawyer had. Now the laparoscopic had again a training problems. The teaching and learning of laparoscopic hernia surgery in India was a challenge. We didn't have, medical colleges didn't have the facilities to show the teach laparoscopic hernia repair. And even when you see in the other videos and all those things, in YouTube, things were not very clear. So the teaching of laparoscopy inguinal hernia was difficult as compared to open hernia repair. And then there was a learning curve in laparoscopy. Now, how many learning cases you must do? The learning curve, in the journal says in 2017, I'm showing all the recent journals. The learning curve is at least 65 cases you must keep on doing, okay, under some supervision. Only then you can learn the technique. And anytime the 65 cases, you may have a difficulty or you may have a complication that your boss or whoever your senior person should save you from that. So that's the learning curve. So a reduction of rate of complication was observed only after 35 cases. So that means till 35 cases, you can have a severe complication, including death. And your senior person or your senior professor who is there with you should be willing to save you from any type of problem. So that is a problem with hernia. Whereas in a case of open hernia, you can see that open hernia is in day case surgery for inguinal hernia, Lycosteen under local anesthesia performed by surgical residents. So that the junior most person can also do an open Lycosteen hernia, and the patient goes home as a day case surgery. So that's you see the difference. One side there's 65 cases you require under supervision for learning curve, whereas in other side surgical residents are able to do it without any type of supervision. Now cost. There's another problem was cost. In India is not a very affluent country, so the cost is again a problem. Laparoscopy, I tell you, in my place, it's something like 70,000 rupees, so it's almost like $1,000, $1,500 you require to do a laparoscopic hernia repair in our country. Not many patients are willing to pay that much of money, and for the benefit which you get, because there's not much of difference as compared to gallbladder. Gallbladder, of course, is a very gold standard method. So we know that, but hernia still not very clear, not very established, and people are not willing to pay this much of money. They will prefer to do an open procedure. Now, what are the contraindications of laparoscopic inguinal hernia? The contraindication is absolute contraindication, as I told you, it requires anesthesia. So patients on whom general anesthesia or pneumoperitoneum is risky. For example, an abdomen like this, so many scars. So prior pre-peritoneal surgery, prior laparotomy is very difficult to insert a trocar inside that, or there's an ascites, there's an bleeding diastasis, or there's some emergency like strangulated hernia or giant scrotal hernia. All those things are contraindications of laparoscopic inguinal hernia, but all those things what you are seeing can be done very nicely with open hernia repair. So what is contraindication is basically becomes an indication for open hernia surgery. Now let's see what the recurrence after laparoscopic hernia. What is the recurrence rate? Many people said laparoscopy was very good, fantastic. Let us see what is the recurrence rate. And I am showing two journals. If you read this, this is again a hernia journal, and this was a very this 2018 paper, 1 year, and reoperation for inguinal hernia repair in Ontario. This is a population-based study, and then they said, you see, I showed you the lines. Laparoscopic inguinal hernia repair is generally associated with a higher risk of recurrence than open. So what is the meaning of that? Laparoscopy is causing more recurrence. If you discuss in conferences, you see many people say, no, 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 there's no recurrence, blah, 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 and all those things. But I'm showing you the journal. That's a documentary. Again, a 19-year study, this again, I see 19-year, almost one of the largest study, a cohort study, analyzing recurrence following laparoscopic and open inguinal hernia repairs. And then what is the comparison? Laparoscopic inguinal hernia, is associated with higher recurrence rate. So both the journals and everybody says laparoscopic inguinal hernia repair is associated with higher recurrence rate. So ladies and gentlemen, no matter whoever says what in conferences, in big conferences, remember that this is a documentary evidence which I am showing you. Why is there recurrence after laparoscopic hernia? So the reason was, again, very nicely said, proper training in laparoscopic hernia is necessary to minimize the rise in recurrence rate in Japan. So even in Japan, they found the same thing. So they said the training is very important. They are not able to train the surgeons. And this is a very nice article by Atul Gawade. I don't know whether you know him. He's a very popular writer. He's a fantastic writer. And he says, what is the proficiency of surgeons of inguinal hernia repair? And he says, any surgeon, who's more than 45 years, and he's not experienced in laparoscopy, and he tries to do a laparoscopic inguinal hernia repair, will cause a lot of recurrence. So any surgeon more than 45 years, inexperienced in laparoscopy, learning and trying to do it, will cause more recurrence than anybody else. So that's the thing. He says the age of the surgeon also is very important in causing recurrence. Now people said that the pain is very less after laparoscopy, like in gallbladder surgery, laparoscopic cholecystectomy. Ladies and gentlemen, let me tell you what is the acute post-op groin pain. This again is surgery journal from 2018, where patients' perceptions of acute pain and activity disruption following inguinal hernia repair. This was a propensity match comparison of robotic surgery, laparoscopy, and open surgeries, and they found that most respondents felt satisfied with their outcome regardless of the operative approach. Further study required. So unlike in gallbladder where we say the pain was less, in a case of hernia repair, if you do a Lichtenstein repair, it is also painless. So laparoscopy cannot be told that it is there's no pain. So they said the patient find that laparoscopy, there's no difference in pain, acute post-op pain between laparoscopy and open. So here also we are finding a problem. Now, what about the chronic pain after laparoscopic inguinal hernia repair? Now, what are there was a study done on 20,000 patients. There was a chronic pain following TAP, and analysis was done in 20,000 patients. And there was again an inguinodynia. There's a chronic pain due to mesh after laparoscopic inguinal repair. And they found that the chronic pain is much more in a case of laparoscopic inguinal hernia repair. The pain of rest was 4 to 5%. Pain at exertion was 8 to 10%, and pain requiring treatment was 2 to 3%. So that's the reason, again, laparoscopy was not getting very popular, was not becoming very popular because there was a factor called chronic pain. Now, what are the barriers to adopt a laparoscopic inguinal hernia repair? This was a beautifully done study where they said, the first thing, as I told you, there was a lack of training, there was a learning curve, there was increased operation time, because laparoscopy takes much more time than your open. There was increased cost, as I showed you. There was minimal benefits. That's again, unlike in other gallbladder or appendix, here the surgery did not show many benefits. So that's why surgeons were not very keen. And then, use of general anesthesia was there. Lack of support from administration. Administration is not very cool because the cost is too high, though. Even the administration was not very keen. Increased complications, as I showed you. And patient also wanted to do an open rather than lap, just opposite in a case of gallbladder. Increased recurrence rate, as I showed you, and use of mesh. So these are the reasons, these are the barriers where laparoscopy was not getting very popular. Now let us see what is the significance in pediatrics and in women. People said laparoscopy is fantastic in child. Now I'm showing you this article, a review article in 2019, just few months back. Laparoscopy was open pediatric inguinal hernia repair. There was a meta-analysis, and see, I'll show you what is the conclusion is. The conclusion says no definite conclusion to decide on the superiority of one or the other treatment strategies, and yet, okay, so that means either you do lap or you open, there has been a no superiority. It's no use. So they said, no, there's no difference between open and lap in a case of pediatrics. So that again goes out. Let's see what happened in women's, ladies. So that's again a study which was done in ladies, and then there's a fantastic thing. In a case of the lady says, women with bilateral inguinal hernia are more likely than men to undergo an open rather than laparoscopic inguinal hernia. So this is just the contrary. In a case of men, bilateral and recurrence, as I told you in before my slides, usually are the fit case for doing a laparoscopic inguinal hernia. Whereas in women, you see what the study says. The woman says, if the woman with a bilateral inguinal hernia, they are more likely undergo open rather than a laparoscopic. So just opposite. So laparoscopy is not very common, not popular even in women and even in pediatrics, as is told by many of the people in the conferences. Now, what is the return to work and quality of life? People said, that if you do a laparoscopy, there are quick return to work, and there's a quality of life is no difference. Again, a study has been done between Lichtenstein repair and inguinal hernia, and then, quality of life, everything has been done, and they found no difference between laparoscopy and open surgery. People are, after doing the surgery, are able to do the military work as comfortable as the lap. Even if you do an open surgery in this military persons, they are able to do the fantastic job as in laparoscopy. So there's no difference between return to work and quality of life. Now, I stay in India, and I'll tell you about the local scenario in my place. The thing is, laparoscopy is not very popular. It's not coming very, there was a study in my place where they said open technique is still superior to the laparoscopic technique. And, we are still thinking of using mosquito net for inguinal repair. And finally, when people go to some big centers and get laparoscopy done, and when they recur and they come to us, what we do is we use local anesthesia and we do an open mesh repair for recurrences after previous total inguinal hernia repairs. So that means the patient has gone to a big center, a big surgeon, performed a laparoscopy, TEP or TAP, whatever it is, has gone to recurrence. Then they come to us. What we do is quietly we do a local anesthesia and do a open inguinal hernia repair. So that's a local scenario in our country. Now let us see our most important textbook, that is Bailey and Love. I'm sure in Sudan also they must be following it. Let us see what does they say. The Bailey Love's the last edition was 2018 one. They say laparoscopic surgery is of particular benefit in bilateral cases and in patients with hernia recurrence after open surgery. As I told you, bilateral, yes, and in a case of recurrence. Now, the guidelines strongly recommend that surgeon tailor-made the treatment of inguinal hernias is one expertise, local and national resources, and patient and hernia-related factors. And finally is the patient choice. Let us decide what patient, if patient wants lap, go for lap. If patient was open, go for open. So patient choice is also important in decision making. Now there is ergonomics, as I told you, there is something called a laparoscopy. The skill is very high skill is required, whereas an open hernia, normal skill. Now you don't require a high skill. Cost high, life-threatening complications very high. Cost reduction attempt not very useful. Whereas in open hernia we don't require all those things. Motivation of the patients, it depends on the surgeon's confidence. That's the very important. If the surgeon is confident, only then he can do a lap hernia. Whereas in open hernia, you don't require all those things. Now, patient satisfaction 2 years after groin hernia repair, any difference according to technique? No. Now, again, let us see what is the outcomes and predictors of complications in open laparoscopy and robotic inguinal hernia repair. The outcomes in open hernia repair cohort were in general superior than the laparoscopic and robotic hernia repair. So that's the study says. Now, finally, let's go to find out what's the patient's preference and what is the surgeon's preference. Let us find out what is the patient, we did a study where there was choosing the repair between inguinal repair with patient preferences and recommendations and guidelines. And let us see what is the surgeons wanted between tap, tape, and open, all those things. Now, after doing both the studies, it was seen an open approach is favored for all clinical scenarios, even for situations where public guidelines recommend a laparoscopy approach. So, ladies and gentlemen, That is the final thing. What is the patient's preferences and what is the surgeon's preference? And again, it was only an open. Now, finally, the two important thing came was known as TEPLICH trial. One came in British Journal of Surgery, one came in hernia surgery. And there was a randomized clinical trial between total extraperitoneal repair with Lichtenstein inguinal hernia, which is known as TEPLICH trial, and the hernia surgery also did that. There was a total TEP between and Lichtenstein hernia repair. There was a randomized control trials. Now this, which was published in British Journal of Surgery, says both hernia repair techniques resulted in a satisfied patient. Mind it, I am showing all this data are all recent, 2019, not even just few months back. I'm not showing any old data. And this is September 2019, that shows again, if you read this conclusion, there's a high rate of recurrence and vascular injuries in TEP. So again, ladies and gentlemen, we are more inclined for the open hernia surgeries, inguinal hernia repair. Now, what is the conclusion? Conclusion is the gold standard technique for inguinal hernia repair is open approach. It's a very simple given by Hyota published in hernia, and this also is published in June 2019, as current as that. As I told you, I'm showing all just a few months back, just 1 year back. Gold standard is still the open approach. Now, open surgery is better than laparoscopy. This is again another journal. They are very clearly given the verdict. I'm not giving the verdict. I'm just showing the journals what they're saying. Another journal wrote, is laparoscopic inguinal hernia an operation of the past? Ladies and gentlemen, it's all written by very, very famous authors. If you read their thing, they are very famous. They said it's no use. And finally, Professor Andrew Kinsnott from Plymouth, he said, laparoscopic inguinal herniorrhaphy has been largely dismissed by the surgical community. 96% of UK surgeons, 86% of US surgeons, and virtually all Japanese surgeons use open repair. So that's, again, the entire conclusion. I'm not putting my conclusions. I'm just saying what has been told in journals so that it is an evidence base. Now, in summary, ladies and gentlemen, let us come to the thing. Those of you who are doing open surgeries should be on doing. There's still now not many evidences, not many documents showing that open surgery is inferior to laparoscopy. We still wait for a few more years. Let us see what is the final data. At the present moment, open surgery is still the gold standard surgery. And as I told you, Guy Fowler said the best repair is the one that works best in your hands. And Nihas said the last chapter of the history of groin hernia anatomy and operative repair of hernia repex has not been written. So let me conclude by saying laparoscopy is still a complementary choice and not an alternative to open Lichtenstein inguinal hernia repair for unilateral primary inguinal hernia. So I hope I am very clear what I am saying. Now I'll give you a little bit of twist, what has happened. Now, as I showed you, the first slide mine was hernia surge conferences, and that hernia surge was, the international guidelines itself was sponsored by Ethicon, BARD, and Medtronic. So there was a conflict of interest. Now, this was the first, if you see, all the famous surgeons are here in this, this was the first attempt to make an American Hernia Society. And I'm showing it because these are all, many of you may not be knowing, there's Skander case, there's a Nihas sitting here, and there's a Robert Bendawade, and there's a Amit from Lancaster area, there's Gilbert, and there's industry representative, and there's a industry representative, and this is Scott. So all the top surgeons were brought one day, and they said we'll form an American Hernia Society, but there was only one condition, that you have to write a particular company's mesh for next 10 years or 15 years. Nihas refused to do that, and that's how it did not click. This is the first picture of making American Hernia Society. What I mean to say is almost all scientific journals were sponsored by the pharma. All others had a conflict of interest. And everything is written, there was, if you see this, so this is why I said there's a twist, all the hernia societies is a blessing of this curse, and who is paying the money, whether there's really an evidence base. So until and unless that we know all those things, we have to still wait for some more time. So this is one of my publications where I've written, no disease in human body belong to the province of surgeons, requires in his treatment a greater combination of accurate anatomical knowledge with surgical skill than hernia in all its varieties. That was told by Cooper, and it still stands now. Ladies and gentlemen, keep on doing the surgery repair which gives you the best result in your hands. Do not bother over the new technique till we will have to still wait for more evidence to come. Thank you.
Thank you very much, Dr. Kaushik, for this very nice and informative and precise presentation about the debate between laparoscopic and open method for hernia repair. Now we are welcome again our professors, our senior consultant, and my colleagues. And it is a time for discussion. Anyone have any comment or question? Please unmute yourself and ask the question.
I'll be very happy. Was the talk informative?
It is a great pleasure. It is a great pleasure to welcome Professor Rashid Ahmed Abdullah. He is a senior consultant.
Yes.
You are welcome, Professor.
Mute the mic right now.
Please unmute yourself, Professor. It could be some difficult internet connection.
Okay. Was the talk audible? Was my talk audible?
Yes, it is audible. Mr. Ahmed Adam, you are highly welcome. Please unmute yourself, Mr. Ahmed Adam.
Good evening.
Good evening, sir.
Thank you very much, Dr. Kaushik, for this elaborated talk about hernia repair. And really, sorry, I came late because of internet issue, and I didn't pick earlier slides of your talk. But one of the very nice slides that I came across is they say that the anatomical knowledge and the perfection of surgical approach, it stands in the hernia repair. I think everyone he master a proper hernia repair will be a good surgeon in the future.
Yes, sir. It's very important.
I had an experience. Please, carry on. Carry on, please.
Yes. I think the line got disconnected.
Okay, I had a
Mr. Ahmed.
where laparoscopy. Yeah, I just said that I had a training in Ware Laparoscopy Hospital in India, and when I came back in 2015, I was very enthusiastic in doing hernia repair, and I referred that selection for very tight indication, those with bilateral hernia, possibly one recurrent.
Yes.
And those patients with hepatitis or HIV presenting with hernia. And really, I faced a very, very good outcome, although the number were very limited. But what I need to say that, as you mentioned earlier, that the complication is life-threatening. And you need a very thorough experience to practice such a routine day case laparoscopic hernia repair. And also, you need to have a learning curve. Every single day, you have to build up your learning curve. And that is not possible to be gained on a skill lab. You see, hernia repair, it has to be done on a live, I mean, you cannot do it in vitro or you have to do it in a live patient. And that is really one of the challenge of hernia repair training laparoscopically. So my question, it is still laparoscopic repair is preferable to open repair on a recurrent or bilateral hernia on those who are having some risk factor like HIV, hepatitis patient, and so on, is still it superior to do it laparoscopically, or it's better to do it open? Thank you very much.
In a case of bilateral hernia and in a case of recurrence after open, still the treatment of choice is laparoscopy, sir. That has been documented everywhere. So bilateral case and in a recurrence, laparoscopic inguinal hernia is the best. Otherwise, we have to still go for there's the open and laparoscopy. In rest of the cases are just the same. Only in a case of bilateral inguinal hernia and in the case of recurrence, laparoscopy has become a gold standard, sir.
Thank you very much.
Thank you, sir.
Welcome, Professor Rashid Ahmed Abdullah.
Can you hear me?
Yes, yes.
Can you hear me?
Yes, sir. I can hear you, sir.
Yes.
I can hear you, sir.
Well, thank you very much. Actually, I had a lot of interruption in the internet, so I didn't really follow it. But I would like, I like really your concluding remarks. I think you put it very good, the indications for laparoscopic. And the other thing is that for surgeons, if you are adopting a technique and you have got good results, why are you changing it? I always say this. So I think you have to take in consideration, especially in developing countries, how much does it cost really for the patient, because we don't have, I mean, the typical insurance outside. So sometimes you have to make the patient pay for many of these things. So I think your conclusion is really very sound, I think, for all people in the country, because there is always, I mean, rush for young people to adopt new techniques without really. And as you actually mentioned, I mean, these are manufactured by companies, and definitely they have got a benefit. I wouldn't blame them. I mean, they have got a lot of contribution in medicine, but at the same time, I mean, you have the dual thing. I would like to get. Well, thank you for participating in this webinar.
Thank you, sir. Thank you.
Anyone have any question, please unmute yourself and ask question or can comment.
It was wonderful talking to all of you.
Mr. Ahmed, you are welcome again.
And I think young surgeons and registrars, they need to have a real more friction and interaction in those lectures, because it are very beneficial. This is number one. My question to Dr. Kaushik is, what about the debate regarding the emerging of a very light mesh in comparison to the standard probably mesh in the past? It is still, we are going towards having such a more than 70% light mesh, or still there is a place for using the classical ordinary mesh? Because here we have a lot of technical issues regarding the patient affordability and the availability and so on. So we know the fact, but we have to tell this fact according to local setting. Thank you.
Yes, sir. The best is to use a light mesh, sir, with like polypropylene or something like that, which we use in our setup. The mesh has to be nicely tucked, and there should not be any seroma formation. So those things has to be taken care of. Light mesh is good enough, sir, in our setup. Or we can also use sometimes a vicryl mesh, which gets absorbed for some time. These are the new things which is important. Mesh, any mesh can be used, provided it is not causing any adhesions.
Mr. Ayman Nasr, you are welcome.
Assalamu alaikum.
Hello, salam, Mr.
Hi, well, it's a pleasure to hear this presentation. Again, I'm sorry I didn't catch it from the start, but I really enjoyed the presentation, and I really still enjoyed the open-minded approach with your answers, because we all still agree that laparoscopic hernia repair is an option that should be mastered, should be available. Case selection is very important now. I think the era of evidence-based medicine made us more aware of case selection. So if you'd like to look at an outcome, you really need to know what you're dealing with and start categorizing your patients. My personal experience with laparoscopic hernia repair is that, especially inguinal hernia repair, I'm much in favor of the retroperitoneal rather than intraperitoneal approach. I haven't really I can't really say that I've done a lot of them, but it was an operation, maybe because of the learning curve, that used to take an average 45 minutes to 1 hour. Again, it's a costly operation. And keeping the training of open hernia in mind, that you could actually get away with it within half an hour or less, make it still a favorable option. I would add my voice to Professor Rashid that in developing countries, still open hernia repair is a very valid and a very useful option. And I totally like your comment that yes, while it is a valid option and people should go for it, still laparoscopic hernia repair should be considered when the criteria fulfills. I think there is one more thing we could add to this is basically, I don't know how to put it in an unbiased way, but I think patient preference as well here calls in, and it has to be respected. That's something that we've always have to keep in mind. It's something that is so funny, because when I started my training, people mostly are comfortable using laparoscopic cholecystectomy. And being able to do an open cholecystectomy was a blessing at that part of the world. So by all means, if you're going to go for any laparoscopic surgery, we really need to make sure that you're capable of doing the open part, because when you need to convert to open, this is where we really get into difficulties. Thanks very much for the talk. I really enjoyed it. Thank you very much.
Thank you, sir. Nice comment, sir. You spoke the real facts, sir. It was wonderful interacting with all of you, sir.
Thank you very much.
If anyone have any question or any comment. No more question or comment. We are really very thankful all the participants, especially thank to Professor Rashid Ahmed Abdullah, Mr. Ayman Nasr, Mr. Ahmed Muhammad Adam, and all our colleagues. Really thank you very much, Mr. Kaushik, for this very nice presentation, and we hope to see you more presentations next time, sir.
Yes, I am liking all the surgeons. My gratitude to all the senior professors who came today, all the senior surgeons. My gratitude, and thank you very much for attending this talk.
Thank you very much.
Thank you very much. Bye.
Thank you.
Thank you.